So to start out, welcome everyone. It's great to see this group together for the first time. I know I'm very excited to be convening you all, and I know it's been a long time coming. So great to actually get us started. Wanted to start too by just thanking all of you for making the time, especially for this first meeting. No, we just needed to land something to get ourselves started. So appreciate that folks may have needed to move schedules around to accommodate, but also just a big thank you to each of you for serving on this group. I know many of you from prior roles, and I've had a chance to chat with several of you that I didn't know, and can really say I'm genuinely very excited to work with this group. I think we have a great diversity of perspectives, but also lots of common ground and common interests. So really hopeful that it's going to be a fruitful forum for discussion and to make progress. With that, I've put together a slide deck for this meeting, and I'm going to go through the agenda in just a minute, but I'm just going to start off with the first item that I had on here, which is introductions. I know lots of folks in the room know each other, and in some cases know each other very well, but we do have some newer faces. So wanted a chance for everyone to be able to put faces to names before we jump in. Do want to try and keep that as concise as possible. So we'll ask everyone just to do a sentence or two on who you are, not kind of full biographies. And I can get us started off. Meg Garrett-Reed. I'm the Executive Director of the Office of Affordable Healthcare. I'm excited to be here. And why don't we start in the room and go clockwise, and then we can go to the folks who are on the phone. So Kevin.
President CEO of Community Health Options.
Heather Perot, I'm the designee for the Commissioner of the Department of Administrative and Training Services.
Mallory Shaughnessy, I'm the Executive Director of the Alliance for Addiction and Mental Health Services.
Bullen Harris, I'm the Chief Government Affairs Officer at Maine Health.
Who's right, I'm retired.
Jeff Sanford. I work for Northern Light Health. I'm VP of Finance.
Kate Endy, I'm the Policy Director at Consumers for Affordable Healthcare.
I'm Trevor Putnaki, and as of today, I'm the President, CEO of the Healthcare Purchaser Alliance of Maine. Very exciting.
Breaking news here in the Advisory Council. Great. Christy, how about you next?
Hi there, I'm Christy Daggett. I'm the Chief Financial and Administrative Officer at AMHC in Presque Isle.
And Jordan?
Sure. Hey everyone, I'm Jordan Rhodes. I'm the Director of Research and Policy Analysis at DHHS.
Fabulous. And Carl?
Yes, good afternoon. I'm Carl Toney. I'm a retired physician assistant, and I am on the Board of Directors for the Southern Maine Agency on Aging and the Executive Council for AARP Maine.
Wonderful. Thank you all. And again, welcome. So for the rest of the agenda, I just want to share, I think that this is an important kind of level setting first meeting. I'll get in a little bit to the office's charge, but I think many of you probably know it's a broad one. There's a lot that can be under this office's purview. So I wanted to start with some thinking about my vision for the office and the direction that I'm thinking of taking it after some conversations, and also cover some of the landscape of the data that we already have available to us. I know we'll be thinking a lot more about more data analysis, but there's a lot out there that's existing. So sharing a quick overview of that. And then really making some plans for our next meetings. I've had some thinking about sort of the next 6 to 12 months and some major milestones ahead. So want to run that thinking by this group and also talk about just some of the sort of business items for the council. So, electing a chair and vice chair and setting a cadence for meetings, sort of some of those administrative items that we need to get started. So I wanted to start with just an overview of kind of the office and the advisory council, given that it did pass a while ago, it might not be fresh in anyone's mind. So to start off, it was authorized in the prior legislative session in their first session of that 130th legislature. Just a quick reminder, the office is an independent state agency, not part of the existing executive branch, a little bit unusual in that sense. So I know that's come as a surprise sometimes when I've been introducing myself to people and, create some differences in how I'm sort of starting up, but really appreciate that DAFS has been helping me out with that process. And the office works under the general policy direction is the terminology in the statute of this advisory council, as well as the committee of jurisdiction, which is the Joint Standing Committee on Health Coverage, Insurance, and Financial Services, HCMFS. And I will use that acronym plenty. I've been working with it for a while. But so it is sort of dual advisors and interests. And I will say, I certainly see the HCIFS committee as a primary audience for this office's work. I think at the time that it was established, there was a lot of interest in this office contributing ideas and guidance and information to that committee. So we'll probably come back to them as well as the HHS committee fairly regularly. To quickly try to summarize the duty of the office or the duties, I really shortened this. So one of the documents that I shared is the authorizing statute, which is a little bit more detailed. But just briefly, there's a significant analytic component to the office's duties, working to analyze cost growth trends and healthcare spending trends, and also some specific language about monitoring the adoption of alternative payment methods or APMs, both in Maine and nationally. And then in addition to that analytic role, there's also a directive to develop and propose policies to do a variety of things. So improving the cost-efficient provision of high-quality healthcare, improving coordination, efficiency, and quality of the healthcare system, improving consumer experience, and improving healthcare affordability and coverage specifically for individuals and small businesses. Having read this myself, I think there's some areas of overlap here potentially, but also I think some deliberation to the legislature is sort of calling out of those different categories. And then the last sort of formal duty I just wanted to flag was that the office is specifically instructed to provide staffing assistance to the Prescription Drug Affordability Board, or PDAB. That group has a statutory responsibility to establish spending targets for public payers or public purchasers. And that's some work that they've gotten started, but I think that in the next year or so, my office will be helping them with a little bit more of the analytic work necessary to kind of fulfill that statutory directive that they have. I'm trying to go to the wrong keyboard. So in addition to those general duties, there are some firm deliverables that the office is required to provide that I also wanted to just review so folks have a sense of them. One of those is holding an annual public meeting by October 1st of each year. So you can guess that's something very much on my radar. I think September is going to be here before I know it. And I'll talk a little bit more about the structure of that a little later when we talk about next steps. There's also a requirement to report annually to both the governor and the HCIFS committee. Exactly what that report looks like is sort of at the discretion of the office, but they are looking for annual updates that I think will be a combination of that analytic and policy proposal directive that I have. And then there is a one-time requirement. I won't read this whole set of language, but I especially wanted to flag this because it's actually not in the office's statute in Maine revised statutes. It's unallocated language, so it can be easy to miss or overlook. But there's a one-time requirement that was passed last year to look at this set of very specific policy proposals, everything from public option to state level subsidies, but where the HCIFS committee and I think the legislature at large wanted to be a little bit more specific about what those policy recommendations look like. I should say, do feel free to stop me if anyone has questions. I'm sure we'll have more discussion on some of the later sections, but don't let me. I'm happy to take a break from talking to you if there's anything that anyone wants to flag for me. So I also just wanted to give a quick update on administrative items and sort of some of the work that's been happening in the past couple months since I took this position. A couple general startup items I shared with many of you. I am set up in a suite of offices at 221 State Street, which used to be the DHHS building over across from the State House. That's a building that, from what I understand, in the medium to longer term, may be undergoing some renovation. So I don't know how long term that will be, but I'm very grateful DAF's helped me with that. I don't have any money for rental expenses in my budget right now. So that's the place I am for the time being. And I think being very candid, in the longer term, when there's an opportunity for a budget request, I'll probably look to find a little bit more of a permanent home where we know we can be settled. But until then, you can find me over at 221. The other item I just wanted to flag was website creation. It seems like maybe a small thing, but I think a little bit of a challenge that I've had is I don't have great channels for communication publicly or kind of public transparency. So I've been working with the state's web vendor, and I think hopefully that'll be ready to go live in July. It's a relatively simple site, but I'd like somewhere where we can just share what the office is, share information about the advisory council and meetings, and post things like the recording of this meeting. Hiring is a big priority. In the authorizing legislation for the office, 3 positions were authorized, so my position and 2 others, so a total of 3 for the office. One of those is a public service coordinator, a relatively senior position that I think is a good match for what I'm looking for in terms of the skill set. So that is currently going through the functional job analysis. I realized I wrote FJA here. Those of you who worked at the state probably know that term, others may not, but it's sort of an administrative process before a position can be posted. But very anxious to get that up. I'm really going to be looking for someone with a quantitative skill set for that position. I think that'll be a good complement to my background. I'm less quantitative in background, and I think having extra capacity to do in-house analysis will be something that's really helpful to the office. The other position that was authorized was an administrative role. And on coming into the position and thinking about our needs, I think with the size that we are, while it would be great to have somebody to just help with little admin items, I think it's probably not the priority right now. I think a lot of that work can be absorbed. So hoping in a budget initiative that I have in the change packet to convert that position to more of, I think it's a public health something. That's more of like an entry level, maybe somebody coming out of an MPH program to be an analyst, to be a little bit more substantive and contributing to the office's work in that way, and a little bit of part-time admin support as well. So just a note on that, because I know one of the questions that I have gotten asked the most and most immediately when I share about the office is it just you, and what's hiring look like, and when is the office going to grow? So working on that. And then finally, there is a process underway to access some of the temporary staffing contracts that the state has that would allow me to bring some fellows in. That's something that I see as hopefully really helping to expand the office's capacity a little bit, to maybe have some graduate students locally or remotely with us on a temporary basis. And in addition to that, just a quick note as well, I mentioned the initiative in the change package to reclassify that one position. I did also include a request for some additional funding. I think it went up from about 40,000 to around 100,000. My current budget right now for everything other than staffing is $40,000 a year, which is a little tight when you get to things like just technology expenses and some of the overhead. So that will help us both with being able to pay those fellows, because that's important, I think, at that skill level, and also have some money set aside for consulting and assistance with from outside contractors. I think as we get more in the weeds and are looking closely at policies, we'll probably find that we need some extra analytics capacity. So I'd like to have a little bit more funding to be able to direct that as needed. And waiting to see how that shakes out. Others in this room might have a better idea what's happening with the budget than I do. I'm just going to wait and see where it falls for right now.
Meg, can you, it's an anomalous organization. It's a separate state agency, but it doesn't have a board.
Mhm.
So there's no governance structure for this group. To whom do you report?
That's a great question. I don't know in the statute that it actually makes that clear. I will say from my perspective, with great power comes great responsibility, I view myself effectively reporting, I think, both to this group and to the HCIFS committee. I mean, not in a formal sort of, there is a check-in way, but I would expect and hope that, I am meeting the expectations and needs of this group. And then also that the HCIFS committee, has some ability to direct my work. Again, I think what that looks like is challenging. It's something I've already been working through. That can't mean that each individual member of that committee can direct the work, but they have, for example, made changes to my statute in this past session.
Governor hired you? I'm just trying to figure out your authority to make sure that you're protected.
The governor appointed me and I was confirmed by the legislature for a 5-year term.
Yeah. But you don't report to the governor.
I don't.
It's weird.
Some of it definitely is weird. I would guess there's probably a story in
I'm sure there is.
in how the legislation moved forward for how that happened. So
Technically a quasi-independent.
yeah.
Yeah.
But you're right that it is unusual in that I think
Yeah.
others like MHDO have a formal
Yeah.
board structure, whereas this is an advisory group instead. So, I will also say, though, I think this office is also somewhat unusual in that we don't ourselves have, or I don't myself have authority to enact things or implement programs or sort of innate authority to operate anything because of that function where I'm really advising the HCIFS committee. There's, I think, any action coming out of this office would probably necessitate legislative action. So that's also a different sort of structure of authority, I guess. Great. For that, I did want to give a quick update on legislative activity. I know lots of folks in this room have been kept very busy over the last few months, and we've been a little bit busy. It was interesting to jump into this role and go right into the kind of the thick of session. So I wanted to flag sort of the bills that I think most significantly impact the office. The first here, LD 914, came out of either task force or work group on genome editing technology that the HHS committee had established, where they were looking to add some language on new and emerging technologies to the statute governing this office. I worked with a sponsor on that. I had some concern about kind of a new additional mandate in the way that it was initially structured. We sort of compromised on just a reference to new and emerging technology in the language, and that we would consider that it's something I think would already kind of naturally fall within the office's purview if there were something emerging that clearly was on the horizon that could potentially drive costs or spending up, but maybe could generate savings. So I don't know the future of that one, but relatively kind of minor tweak to the language. LD 1856 was a resolution with some changes to that one-time study requirement. Those of you who have been in the HFS committee this session probably know there's a few members who are very, very interested in public option, single payer type of plans. So they had some interest in prioritizing that study kind of above the other options in the legislation and asking me to deliver that sooner and with some more depth, not actually sooner on the same timeline, but with some more depth, and then pushing back some of those other policy ideas and giving a bit more flexibility on the timeline there. So this is one I testified neither for nor against and really said this is up to the committee's discretion to sort of decide if you want to redirect me. But that would be an example of the committee, making a collective decision in terms of the office's work. LD 1792 is a rural health task force. This is one that would be convened and staffed by this office. Pretty broad mandate to kind of look at rural healthcare costs and delivery and sustainability of rural hospitals, and with quite a tight timeline for a report to be delivered. So this is one, I will say the others don't have a fiscal note attached. This is one that had a fiscal associated, because I think we would definitely need some support and help, especially while the office is just myself to deliver that. So not sure how that one will land. And finally, just a couple of task forces being considered that I would be an ex officio member on, one on facility fees and the other a Blue Ribbon Commission on Guaranteed Healthcare. That's one that I think started a little bit broader, but was narrowed a bit. Again, kind of coming out of some of the interest in the committee in universal coverage and publicly funded plans.
Put a lot on your plate here.
Deadlines for these complicated.
I definitely, it's not even, not everything is reflected in this list in terms of different times, as again, those of you in the room know, where people said, well, maybe this should go to the Office of Affordable Healthcare. So we will see what else maybe comes my way in the form of letters or less formal directives. But it's nice to see the enthusiasm about the office. I'll say that, but definitely a need to keep some parameters. So moving on to an overview of the advisory council, and I'm just checking how I'm doing on time because I am okay, not too bad so far. Again, just to give a grounding for this group, the council's directive is to advise the office on matters affecting the cost of healthcare in the state. The group will need to elect a chair and a vice chair a little bit later in the next step section, have some thoughts about the process to do that. But I think over time will be a little bit more self-governing, sort of in partnership with me, though I took the reins on this first meeting. The group is required to meet at least every 2 months, and meetings can be added or canceled by the chair. Quorum required for action, probably pretty standard for other groups that some of you may sit on here. And just a flag that our DAPS and DHHS colleagues are non-voting members for those purposes. And then just a quick flag that there are some recusal requirements for conflict of interest. I think we'll work together. Heather graciously had offered some help and advice to me in terms of the formalities of convening groups like this. So at the next meeting, we'll probably plan to share in advance of the meeting and bring a conflict of interest agreement that's other groups have used. But just something I thought I'd mention, sort of knowing this group, not too concerned about it, but just to make sure that you're all aware and thinking about that as issues come before the group. Moving along. If there's no questions on that section, jump into kind of the thick of the presentation, which is some slides I put together on the landscape of healthcare costs. I will just say upfront, I don't think that the information in this section is likely new to many of you. So not sharing this from kind of an education perspective, really the reason I wanted to walk through it with this group is it's my thinking about how to frame up this problem and how to begin to discuss it for other audiences, like legislators, like potentially the public meeting in September. This would be sort of a foundation of, again, how to think about that presentation. So wanted to share it mostly so that I could get feedback from all of you. Towards the end, I've got some research questions that I've already come up with, but especially would love to hear from this group about what else should be on the agenda. So jumping right in, I am a big fan of trying to frame a problem before talking about a solution for it. So I did my best on this slide to just pull out a few of the facts that I think do the best job of kind of expressing why I think my office was created and why this group was convened. I'm sure it's a statistic many of us have heard before, but knowing that the US spends most money on healthcare of any developed country, but has the shortest life expectancy. And there are several other metrics of kind of quality of care where the US underperforms as well. So life expectancy not being the only one. More than a third of Mainers who are surveyed recently had delayed visiting a doctor because of concern about cost, and nearly 70%, kind of a stunning percentage, believe that just one major medical event or illness could cause a financial disaster for them. I will say, I think talking about affordability can be challenging. There's been a lot of efforts to quantify what affordability means for consumers, and it's difficult to do with varying circumstances. But the reason I like talking about deferral or delaying care is I just think that's one of the most tangible ways that we can know that affordability is not just a burden in the sense of, you know, directing resources from something someone might prefer to spend on to something nobody frankly ever likes to spend money on, to really being, to knowing that that's actually impacting the care that people are receiving, their quality of life, and frankly, in many cases, I think probably driving up spending to some degree as well, because we know many of those folks will end up in a site of service that might be more expensive in the long run because cost is discouraging them from actually accessing care when they need it. And then lastly, I came across this statistic, which I thought was just really interesting from a national survey, that nearly 90% of large employers said they believe that the cost of providing health benefits will become unsustainable in the next 5 to 10 years, and 85% are expecting the government will be required to intervene. I think, at least coming from my background and at the state level, we often talk more about the individual and maybe small group markets, but seeing this level of concern from large employers nationally, I do just think is a real sign of the urgency of talking about solutions in this area, that kind of working and maintaining the status quo is probably not going to be sustainable for us, given the level of concern that they're expressing in other data that we've all likely seen about the burden that costs are placing on businesses. So then I've got a section of slides really looking at kind of the macro level of data on health spending in Maine. This first slide is looking at national health expenditure data. So this is from the CMS Office of the Actuary. It's representative of all spending on healthcare goods and services. So a very pretty comprehensive measure, I would say. And you can see here that means per capita spending on healthcare is higher than the national average and has also been growing at a faster rate in recent decades. According to this data, Maine has the 10th highest per capita health expenditures in the country. So I think helpful to, with that comparison to the US, sort of know where we stand and know that the problem is potentially even more acute here in Maine than in other parts of the country.
Is that age adjusted or?
No. Yeah.
I was wondering how much that was driven by our older population.
Yeah, it's a good thought. And I a little later on do reference. I think that that's a part of the driver, especially seeing the trend over this time. So one of the research questions I have is actually trying to look at something similar, but do age adjustment.
And this is all healthcare.
Yeah.
Does this include corrections healthcare or other healthcare?
There is a very long document on the methodology, but I think corrections would be included. I think the only exceptions to spending in this are government spending on public health, research institutions, and then there are some like ancillary costs associated with the administration of health plans that aren't included, but by and large, health insurance costs are sort of included and incorporated into the measure as well. So yeah, it includes pretty much all payers. Okay. I also wanted to include a quick snapshot from the Maine Health Data Organization that I think shows a similar trend. This data is pretty different in that this is only representing claims for payers here in the state and payers that contribute data to MHDO. And we know there are that's not comprehensive of all payers, but generally, telling a similar story here in terms of the growth, especially in total commercial spending, some growth in Maine care too, although we know some of that is associated with growth in enrollment in the Medicaid program, especially in the last couple of years. I didn't include Medicare on here because it's a little bit difficult. Medicare Advantage and traditional are split out in this analysis, and so it's a little harder to follow trend there. But I did want to just call attention to the report that I pulled this from. So this came from a baseline health spending report that Maine Health Data Organization put out right around the beginning of the year. That was actually done sort of in service to this office before I was appointed, where there was a structure. There's a Tableau dashboard that they created where you can go in and play around with this data, look at service categories, break it down by different payers, and there's a few different measures there. So it's something I'm going to be digging into a little bit more with Karen Lee over the next coming months, both making sure that I have a good understanding of this data, because there are some nuances to MHDO data that I want to make sure I really have my head wrapped around, but also talk about other analysis that we can do with their data.
Does this include, does it include the additional federal funds post for COVID? Is that?
That's a good question. I don't think so, because it would only be claims based.
All ages. So including 65 plus the death, nursing facilities, home care agencies.
Yes.
That's really why you see the big discrepancy between taking care of this.
Yeah. Yeah, absolutely. I think it's both those things. I think the growth, I did think it was interesting seeing the trend in per capita spending for Maine care, though my hypothesis with that would potentially be, expansion population coming in and potentially having kind of lower health needs than the prior population. So
It's
less
also
to do with spending. Yeah.
It's having a huge impact.
Yeah.
So as they do the redetermination, you're gonna see that number go back up.
Yeah, absolutely. You could probably say it at any time in health policy. A few years ago, it was the ACA is being implemented, but I will say, looking at data in these prior 2-3 years, the combination of COVID and then some of the policies coming from COVID do definitely make it a little bit harder to know if the trends that we're seeing are long-term trends. So in general, I've been trying to look a little bit longer to get a sense of directionally where things are moving, because the last couple of years have been different ones. You can say the same if there's that much impact from continuous coverage in Maine care, then part of my question is, well, what does that mean on the commercial side? How would those numbers look different if potentially that population were covered commercially or uninsured?
We're gonna find out.
Yeah.
I can talk unwinding. That's what I was spending a lot of time thinking and talking about 2 months ago. So yeah, definitely going to be a eventful year or so. This next slide comes from that same initial data source, national health expenditures. Just wanted to get a sense of how spending breaks down, and this data is specific to Maine. So hospital care is definitely the largest percentage of total health spending. I will say this is one where I did take a look at prior years to see if they were comparable or if there was anything unusual about 2020 because of COVID. And somewhat surprisingly to me, actually, they were pretty directionally similar. I didn't see significant sort of shifting, maybe because my, again, hypothesis was hospital care would be inclusive of things like elective procedures potentially that decreased during that time period. So following that are physician and professional services in terms of the share of spending, and then prescription drugs coming in at just under 12%. So I think just helpful to get a sense again of how the spending at a macro level divides across services.
So the distribution was similar in 2020, but I assume that the amount was lower.
It actually wasn't. I know, it was interesting. Definitely, it's an area I'd be interested to dig in
Yeah,
a little bit more.
Because certainly, I would bet Jeff would agree that the health systems certainly saw greatly reduced revenue in 2020.
Yeah, all I could think of at the time was, I mean, I've never heard of costs of care for people with COVID, outpacing the delayed or deferral of care. So that was my one thought, but I agree. It
And
seemed
our surge was in
unusual to me.
2021.
Yeah.
So that was our end of 20. Into
But
2021.
again, it would be interesting to see, is there an impact of the dollars that came in?
Yeah.
Federally,
That was not till 2021.
the dollars didn't rise, it's when.
It's a good question. One thing I didn't do was take a look at the national version of this breakdown in other states just to see how it was comparable.
I'm surprised by the relatively low percentage that prescription drugs
Yes.
takes in this pie. And maybe because of what I focus on in terms of our own population, but we see just on the retail, the prescription, well, home delivery as well, but on the prescription drug side, not prescription drugs in a medical setting, but retail home delivery, it's at least 20%. And then add drugs in the medical setting. So it's probably 2x what.
But it may reflect the role of Maine's hospitals that are more comprehensive, doing a lot of behavioral health stuff, a lot of 340B, a lot, all of which are medically based.
They'll show up in RX.
I don't think it does. Hospitals.
No, because it's prescriptions that were.
Yeah, we got to the medical side, I think, but.
Yeah, medically, hospital-based. Hospital.
Comes to-
Goes as hospital, not prescription.
Yeah, but we're seeing the same thing in our book of business, 20% pretty much right on, and then another 5% or so if you take the drugs on the medical benefits, so about a quarter of spending on prescription drugs for the commercial population.
I was gonna say one thing I just made a note to take a look at. It's a little bit harder to do a payer breakout of this data just because of issues around cross-border care, especially for the commercially insured population, but could take a look and see what the commercial breakdown looks like, because my one other instinct is, the division of spending in Medicaid may look somewhat different, or how that's sort of factored into this overall division, maybe pulling that down a little bit. And this is where, I referenced definitely as I was looking over this data and thinking about conclusions to draw or takeaways, definitely had our aging population in mind, acknowledge that's likely a factor in terms of utilization. I was looking, wasn't sure if we still had this title, but I do think that we have the oldest average age in our population, and we have quite a high percentage of our residents enrolled in Medicare relative to other states. But that being said, looking at the data, I also think that, higher per capita spending or prices are a factor in higher per capita spending as well. I know there's been some evolutions of this data coming out of RAND in terms of spending, but on average here, hospital prices are 275% of Medicare prices. We know always commercial prices are higher than what Medicare is paying for services, but we are a little bit, further on the high end of the spectrum in terms of that relative price, which I think is a contributing factor to spending here as well.
And is that price or is that reimbursement?
Reimbursement. Yeah, I should have, it's a good flag. I was going to say when I'm saying prices, I'm using that in the context of like what a payer is actually paying as opposed to list price.
Before we move on your problem statement, I wonder if there might be some value in adding demographics in terms of the aging of, not just the aging of the population, but the workforce.
Yeah.
Because the workforce issues clearly drive.
Yeah, that's a good flag.
Very high percentage of people. Right, our highest percentage of duals in the country.
Yep.
Yep, that's very fair. I'll definitely add that in. That's a good thought.
But I do think the workforce issues are going to drive.
Until we get robots.
The Democratic caucus.
I'm checking myself again. Oh, we're like a little ahead of schedule. That never happens. I shouldn't jinx it this early, but. So then, after talking a little bit about macro level trend here, wanted to spend a little bit of time just talking about what that means from a consumer perspective and the data we have available on that front, again, pretty specifically for Maine consumers. I think I often think about the way that consumers experience healthcare costs is through insurance and traditionally, I think premiums and what was happening in terms of trend with premiums. I think it's worth noting that increasingly, and I have some more data on this that I'll touch on later, but there's a trend of higher deductibles in both employer-sponsored insurance and the individual market that creates some more exposure directly to health care prices and healthcare costs for consumers. And I think that that's behind a little bit of, the energy and conversation over the last few years and some of the more compelling kind of consumer stories that we hear in this space. On that note, I came across this analysis that Forbes did where they tied together multiple different metrics for affordability. So one was total spending, but they also looked at survey results on delayed and deferred care and a number of other metrics and found Maine to be the 7th most expensive state for healthcare. So again, we do tend to maybe not be right at the top of the list, but often in these measures or studies to be in the top 10 or top 20.
Surprised that Massachusetts.
It's usually number one.
No, that cost commission has worked. I mean, they have, but it's interesting, rurality is a trend here. Yeah, I don't know about Delaware, but.
Well, is this just commercial?
This is consumers writ large. So I was going to say, I think like in Massachusetts, they do have the very, very generous Medicaid eligibility, for example, that I think would make a difference. Although one of the metrics is spending. So it's a little bit more complicated. Again, it's tying together multiple metrics and the spending would be multi-payer, but at least one of the others might have had to do with out-of-pocket costs, which would be more influenced, I think, by the generosity of their public programs.
I think older, also the age is a factor.
Yeah.
So
Yeah, rural and Asia.
Don't they have some state subsidies that they
In Massachusetts, yeah.
help lower premiums?
But read the Massachusetts Cost Commission work, it's fascinating.
Yeah, I don't know now that it comes to mind, their baseline, they've definitely slowed, I think, growth over the past few years. So maybe that's having some impact.
We know
If this takes into consideration, or if there's a source for tracking this at all, employer contribution to HSAs when a high deductible plan is put in place. Because that might show up as an expense to the consumer, but if the employer is funding it, are we seeing that?
That's a great question. I don't know off the top of my head. I'll have to look at that. Yeah. Yeah, because traditionally what I've seen, focuses on employer contribution just to premium, and I don't know if they have found ways to be inclusive of HSA contributions.
I think that's becoming a much bigger piece of how employers are addressing this.
Yeah, definitely. That's a great point. So moving on, I thought this was an interesting another way of thinking about health expenditures as a percentage of total personal expenditures. So I will say, definitely acknowledge as I was looking at this, I was thinking about trends we've seen in Maine in the past few years in terms of housing costs, going up significantly, and that some of this is the other pieces of the pie that are maybe eating up more of people's budgets as opposed to decreases in total personal expenditures. I will say left this scale as a little bit narrower just to show the differential between Maine, New England, and the US. But one thing I just flag overall that I think is worth remembering is, we're up well above 15% in terms of the percent of total expenditures that people are devoting to healthcare, which again, just even as a baseline, I think is pretty high. So it's about trend here, but also, just the situation in which we find ourselves in terms of how much folks are having to devote to this. And obviously, wide differentials in terms of personal experience here. This is an average across lots of different populations, but we know there's a lot of folks for whom or who might not be utilizing care at all. So it says a lot about some of those households with higher healthcare needs and what their percentage is. The other thing I just want to note, and sort of coming back to Kevin's point, I was somewhat surprised to see Maine higher than this New England average. Maybe some of that is income levels in other states, but especially thinking about New Hampshire and Vermont potentially as somewhat comparable to us. You know, we are above that New England average in addition to being above the US average. Chatted a bit about deductibles, and this definitely, Heather, you know, may play into the overall trend of moving towards higher deductible plans in combination with HSA. So do acknowledge that, and I'll make a flag to look into this metric in particular and try to understand that. But again, thinking about it in comparison to other states, this one really jumped out to me in terms of how high we are in the measure and how much higher than US average we are here in Maine in this trend of higher deductibles. This one is specifically looking at employer-sponsored insurance, so not necessarily including individual market plans where we know deductibles tend to be even higher.
Like these look pretty low comparatively.
Yeah.
Yeah, I've seen data saying we have the highest individual deductibles.
Oh, interesting.
I'll have to check the source.
Okay, yeah, do let me know. I'm happy to look at others. But again, I flagged this. I think we all know there's trade-offs here, right? That deductibles and higher deductibles are often, you know, helping to keep premiums a little bit lower. And that maybe for a population that's very healthy, that's an okay trade-off to make. But I think, again, as consumers and from their perspective are experiencing this, they're really struggling often, I think, with the out-of-pocket costs of care, and that can be a significant challenge in terms of accessibility and actually utilizing care when they need it.
Trevor, was that on the individual market that you were referring?
I think it was the commercial market at large. I'll have to go back and check that.
This, I think, I'm reading this right, is just employer sponsored. Maybe it's the combination that drives the stuff.
Yeah, I'm not sure. I'm pretty sure it's the Kaiser Family Foundation data that had us at number one. And yeah,
Take a look at that.
what was it? Highest individual deductible and highest prevalence of high deductible plans.
Yeah, that's been.
Yeah, I did think that was interesting. I had noted that in some of the older data. Do wonder, I know Maine had coverage requirements predating the ACA in some cases, so there may be some historic reasons for kind of a higher baseline, even in prior years.
I mean, age is certainly a factor. The rural nature is certainly a factor, but these are all just symptomatic of costs going up, right? Employers running out of options to be able to shift costs.
Has there been a post, my data is old in my brain. Has there been a post ACA change in the makeup of the number of individual, how big is the individual market?
Right now, it's, well, combined on exchange and off exchange, probably a little over 60,000. Between 60 and 70, yeah, it's just
And now
under
it's been
60.
combined with small group as well.
Oh,
The markets have been combined.
yeah, so the 60,000 would include individual and small group.
No, that would be more like
I think it's
20
bigger.
probably.
The 60 is still larger than it was, so.
Being subsidized by large group. That combined individual and small group, there's being subsidized by.
You mean through the reinsurance program?
By the GAR.
Yeah.
Okay. This is a little bit of a, you know, similar data point, but a different way of looking at it. Again, just not deductibles in comparison to other states, but deductibles as a percent of income, where again, we're an outlier up here in the Northeast. I'm remembering with this with the slide where I looked at 2010 and thought, oh, interesting, we were really an outlier then. And now, you know, a lot of the country is kind of following in this direction. But that we've got certainly not the highest, but a relatively high deductible as a percent of income, which again, coming back to what's the human experience, I think that that's helpful to think about because, you know, $1,200, $2,000 deductible obviously is looking very different depending on the income that you've got and the savings that you have to defray an unexpected care event that you need.
It would be interesting to know too, if things like HSA contributions are factored into this income figure because they are part, obviously, of compensation. I would guess that they are included here.
Yeah, like I said, that's a great flag. I'll make sure to take a look at that on this and just generally moving forward, try and get a sense of and sort of make sure to know whether or not they are included. Feel free if you
I'm
got
just,
anything else.
Going through my head is HSA contribution reportable to the IRS? Is that a way to capture it? But I don't think it is reportable as income.
A good question. Bureau of Labor may have. There's, I think there must be a
taxable
way.
income. I wonder if it shows up as like somewhere where it's not taxed though.
Yeah. I'm sure, I think it's gotta be reported. We can put heads together on that. I agree. It's really interesting. I actually was just a couple weeks ago at a meeting of they were the Maine Association of Health Underwriters. Now they are something else. They have been renamed nationally that I don't remember their new acronym. But they were having a presentation sort of on ICRAs at HSAs and knew it generally, but I think definitely heard a lot of feedback from that group about interest in utilizing HSAs in some cases. Interestingly, less for health expenses and more as retirement savings vehicles. So I think the future of that will be interesting to watch at a federal level. But again, I definitely acknowledge that that goes hand in hand with the increasing deductibles and is worth understanding a little bit better. So finally, just a few statistics. There's a relatively recent survey that Altarum did on surveying Maine people, pretty decent sample size that they had here. And I know this ties into the problem statement, but well over half experiencing a healthcare affordability burden in the recent past. I did think that, half of uninsured adults citing that health insurance was too expensive as the major reason for not having coverage. Helpful. I've spent a lot of the last 2 years talking about awareness of the marketplace and coverage in general, but we know affordability is important there. Of course, I will also caveat from my prior experience, that's their perception of the cost. And there are definitely cases where we know that people may believe that they know what it's going to cost them and be very surprised when they face the reality. But I still think it's worth noting that it does continue to be a driver behind that remaining population of uninsured that we have here in the state of Maine that I know we'd all love to finally close that gap. 14% reported being unable to pay for basic necessities like food, heat, or housing because of medical bills. And then this 80% report being worried or very worried about affording some aspect of healthcare in the future. Know that that's a little bit qualitative. It's a different metric than saying this has happened to me. And maybe people are very anxious, but I still think that's pretty staggering. 80%, that's a huge component of our population. So just wanted to mention that. And I think continuing to try to incorporate a little bit of the survey data alongside some of the more kind of empirical analyses of numbers is helpful, again, in understanding why this continues to be an issue that people raise with their legislators where, continue to sort of have dissatisfaction or concern or anxiety about.
I would just note that Consumers for Affordable Healthcare conducted their own survey recently and found results largely consistent with these, but it may be some slightly more updated data worth checking out as you do that.
Yep, I may have stated yours on the earlier slide, and then this one I knew where to find it all online. So, but I agree. I think looking at it, I generally thought directionally was pretty similar. Yeah. So then I wanted to move into a little bit of addressing this question of why, what is driving this? Again, having been in the HCIFS committee, lots of discussion of the problem, lots of frustration about this, but I'm hoping that my office can move a little bit towards the why and therefore solutions. For now, this is definitely looking more at national data, so just want to acknowledge that up front. It's what exists and is available right now, but I think it's some good inspiration for potentially lenses and different ways of looking at this data that we may be able to replicate on a state level if it's informative, and that might give us a higher level of insight. So the first sort of question I wanted to answer was how medical spending compares to other goods and services. Again, probably in this room, we know this, but I think it's worth calling out for others, how much the spending on medical care is outpacing spending on other goods and services. That it suggests that factors kind of unique to the health sector are part of what's driving this, as opposed to this is just the trajectory of inflation. And I think that's especially important to remember again this year with what we've seen in terms of general inflation, a little bit of an outlier, but there's this really strong, consistent trend over a significant amount of time in terms of healthcare spending really outpacing inflation. That again is really concerning. So then looking at per capita spending in the US compared to comparable countries, part of the reason I wanted to sort of make this comparison coming out of that question about outpacing other spending is just thinking about, okay, what are the factors that are, driving that potentially? We know that other countries are finding ways to provide quality care, more efficiently, presumably, than we are. And I thought that this was somewhat surprising to me and informative, looking at inpatient and outpatient care here in particular. You called this out a little bit already, Kevin, but it was one where I was surprised that the differential in prescription drug cost wasn't larger. Obviously, we've talked a lot about our processes. And I say we've talked a lot, the legislature and I think publicly about drug costs and different ways that we determine or don't determine what the prices are that we pay for those when compared to other countries. And obviously there is a meaningful difference there, but they're really the major difference and driver is inpatient and outpatient.
What would fall under administrative? Would that be like health plan administration or like provider administration or
That's
PM?
Good question. I don't know. I can follow up on that to be sure, but I think it's the
No, it's like
combination of the
you
two.
memorize the methodology for every
In the past, I've used this data source as well, and it's been health plan, it's primarily our health insurance system.
So not inclusive of like costs for health systems in terms of complying with billing requirements or.
I don't believe so, but we could double check that.
And I have a question, which is, where is behavioral health in all of this?
That's a good question.
Breakout. Since long-term care is broken out.
Yeah, I would need to follow up on whether that's, I would guess inpatient and outpatient, but whether that's in preventive or not, I don't know off the top of my head. That's a great flag.
Inpatient and outpatient, but what is the percentage?
Yeah.
Interesting.
You don't track that very well.
Is preventive then,
Past track that.
right, is preventive then like public health or something else? in this bucket?
That kind of
I
thing.
think so, yeah.
That's surprising.
Yeah, I would have guessed,
See us.
Screening, vaccinations.
But look how.
Spend less.
I know.
So we're
nobody ever
spending more.
US is higher. This-
I know.
Yeah.
yeah.
Not much.
I want, but it's still kind of.
Still, yeah.
I wonder if the prescription drug, when you think about the Medicaid discounting of drugs and the numbers of heavy drug users, prescription users in Medicaid, I wonder if that's a factor in our apparent lower rate than we expect.
That's true. Yep. Yeah, again, another where if you were looking at a similar breakout specific to commercial, it would probably look pretty different. That's a great flag as well.
Here in the prevent one.
I was looking at the long term and I was wondering, does that include the costs of things or just the actual healthcare?
Yes, it's inclusive of all of the
Yeah.
long-term care bucket. I understand that.
So it could include some behavioral health.
That's true.
No, behavioral health is never really considered in long-term care, even though
Yeah.
it is long-term care, but it's just not, it's never in that bucket.
I think what we would find is we'd be surprised at how little we spend on behavioral health.
Exactly.
Yeah.
And
A small number.
Sounds like we can probably all agree on that.
Might hold out in other places.
That's a fair
As a result.
I will say on the long-term care, that was one that I had thought may be a result of just more comprehensive programs in other countries. Think about the degree of in-home support that some countries provide, exactly,
Right.
that some of that may be,
Right.
reflective of like really a gap in the care that we're providing and the fact that we. Yes.
And all the waiting list people are on, the people who need long-term care that can't find it.
Sort of like more reflective of what utilization of that probably should look like. Yeah. The next slide I had is really that same data, just represented a little bit differently, looking at the sort of share of the contribution and difference in spending. So again, not sure that we didn't already discuss, but I thought this was just a helpful way of visualizing what we saw there. So then obviously throughout this conversation, we've gone back and forth a bit between price and utilization, acknowledging that utilization here in Maine is likely a driver of higher spending because of our population. So this is one where I especially want to acknowledge this is national data from the Healthcare Cost Institute, and they also utilize data from a few different large payers in the country. So they've got CVS Aetna, the Blues, Humana, and I think Kaiser Permanente in their data set. So definitely this is not like national health expenditures. That's a really broad look capturing everything. This is limited to those plans and commercial costs. But that being said, probably, a fair reflection at least of national trend. And looking here, obviously the past few years, really dramatic drop in utilization and spike back up. That is a contributor to increasing spending. But in the long term, the cumulative change here is much more significant in prices as opposed to utilization, which I think suggests that obviously both are contributing factors, but that prices is pretty meaningful and potentially the more significant driver of increasing spending than increased utilization is.
So again, I'm wondering what price means here, because we know Medicare and Medicaid have barely increased reimbursement. So and given this is the Health Cost Institute, I think this is commercial.
Yeah.
And this it feels a little bit like it's missing, there's a gap here as it relates to what we've seen for reimbursement from Medicare and Medicaid. Because the prices, and whether this is price or reimbursement, has to reflect the whole. And this, I think that's not.
Yeah, so this is reimbursement. Again, it's like prices in terms of actual spending by the plan, not list price. And it is that spending just divided by their utilization number that HCCI uses. So acknowledge that. Definitely, this is looking at commercial specifically. It's not, claiming to be a whole picture look. But that being said, I still think it's helpful in terms of looking at commercial price and the trend there. That again, it at least just illustrates. Not trying to get into the question of why, I guess is what I'd say, Katie. Those prices have increased, but that price increases are a factor. Just again, helpful, I think, for folks less familiar with the data to understand, because if you are looking just at spending, I think there's a valid question. Again, we've all said, well, what does it mean in terms of our population? Are people just utilizing more, especially when we're looking at 2021? Is that deferred care? So just trying to illustrate that both are factors without, again, trying to say that this answers why those prices might be going up.
You've probably seen this, but HECI also has this data broken out by inpatient, outpatient, professional, prescription drugs, all those line items for both price and utilization. Largely tells the same story, but you see utilization dropping pretty significantly as price, however you want to define it, increases.
Yeah. Yeah, I had seen that.
Does HCCI now cover all they didn't, I think they never had the Blues. Do they have them now?
They do, yeah. Yeah, through there, they have like a spun off subsidiary that just does Blues data, Blue Insights, I think it's called, but yeah, they have access to that data now.
So this data reflects them broader than their old.
Yeah. Yeah, I will say, acknowledging again that it's high level and a data set, I think some of this analysis I will say is really helpful. I think it may be analysis that's worth thinking about kind of tailoring to our own needs and seeing if there's ways that we could replicate using MHDO or maybe MHDO and health records data to try and think about, seeing if we could drill in and do something similar. Because I do think it's some of the more insightful data that's available. And similarly, I think we could think about if we were using MHDO data, think about public payers in that as well. So then again, the national data, I'm sure there will be some reaction to this, but I just thought it was helpful to share, trying to think again about how does that spending, how is it reflected in the more consumer facing aspects like premiums. So this is, again, just national data, not specific to Maine, but looking at the trend in terms of what workers are paying for their health insurance as opposed to employer share, both rising pretty significantly, but now worker share, outpacing that quite a bit, and just seeing how that compares to workers' wages, that growth there has been much, much slower. So really tells the story a little bit more about why spending on health care is taking up an increasing percentage of income and total spending for households. And then this is coming back to deductibles, again, and again, acknowledging this is another where understanding where HSAs come in is likely going to be helpful. But just another representation of that like really significant growth in deductibles here. And that, you know, the experience of consumers from exposure from those higher deductibles is worth noting.
As is the 2017 date.
Mhm. Oh, yes, thank you.
Four times.
Yeah.
I'll have to check and see if Kaiser.
Last one was
Yeah.
ended in 2018.
18, yeah.
Like,
This was from a pretty recent publication from them, so it may be that there's more of a delay on the access to this commercial
Yep.
information, but yeah, thank you, that's a good flag. I would guess that we can probably assume pretty somewhat similar sort of trajectories and further growth there. I did think the trend in copay was sort of an interesting one to note there as well. Sort of a similar, you know, trend there in terms of coinsurance, creating a little bit more exposure for consumers. Though, and I may be almost my questions page, I will say this is one where I'd really like to take a look and see if we can do something similar with state level data. I find that very challenging. We have lots of data on individual market, but a little bit harder to wrap our arms around commercial. So would love thoughts and input from this group and others about how to do that. Because I think seeing how closely we follow this trend versus whether we're an outlier to any degree could be pretty helpful. And there we go. I should have skipped ahead one slide. I thought I was almost to the end. So this is where I just noted some of my research questions and my dreaming big about what we might be able to do. Again, really thinking about that age component. I will say it's a constant frustration to me in this field that no data is ever perfect, right? There's ways we could adjust everything. But I do think that the age component is significant enough here in Maine that it feels like it might be worth factoring in and making some adjustments for. Another that I'm curious about, would love thoughts from this group either now or in future about is about the MHDO data. My understanding is that that's claims based only, so it excludes capitated payments, sort of anything under alternative payment arrangements. And I'm interested in whether that's still minor enough that it's not really worth worrying too much about. If we still think directionally that data is probably, you know, pretty accurate, or if that's something where we may need to think about, are there ways that we can capture that spending? So I know there's folks in the room with some experience in that space. Again, would love thoughts, though won't put anyone on the spot now, but something for discussion, because I would like to understand that, especially given that this office is thinking about the promotion of alternative payment methods. Don't want to totally discount that, especially I will say too that it occurred to me that it may have a very different impact in primary care spending, for example, than hospital. So like the impact might be uniform, might not be uniform across services. So we're thinking about a big question, but just digging in a level deeper in terms of services, geography, input costs being the most significant drivers of increasing spending, can definitely incorporate in there, Katie, your point about what does payer mix look like and how is that, you know, how is that trending? And then the one that I most recently noted, just trying to do a little bit more if possible of a state level analysis of similar trends in health insurance writ large, so not just individual markets, but trying to flip it commercial too. Pause there for a moment, just in case anyone has. I know it's a lot to take in. So again, everyone can digest too and follow up with me. But over time, would love thoughts on this agenda. I myself won't claim that this is comprehensive of everything, but again, just trying to think a little bit about what we might want to spend the next several months trying to do in-house or replicate or kind of get to the bottom of on a state level.
One thing that you haven't addressed at all is quality care, and obviously that is much harder to measure. But it's something that I think needs to be somewhere in this mix, as we need to make sure that while we're pushing on costs, we're not negatively affecting quality.
Yeah, it's a good point. I will think about how to incorporate that. And I can say that across all the data that I have seen and looked at, there's a pretty consistent through line of there not being a relationship between price and spending and quality. If there were, I would, flag and say, it looks like, oh, if you're squeezing here's what the outcome can look like. But typically there doesn't seem to be a big relationship. So that is great feedback. It's something I think I'll need to think about how to incorporate thoughtfully, because the one thing is, I think it needs to be in the context of what are the impacts on thinking about affordability on quality, just because quality is such a big scope that it's like, that could be a whole office on its own. But it's very fair to point out. And at the bare minimum, definitely want to make sure that I acknowledge that, and I can include some of that data in terms of correlation between the two that exist.
Else that I think probably add to the mix would be emergency department use. By demographics. And also average length of stay. I know that's been really a challenge. Issues. And also, looking not just at hospital workforce, but nursing home workforce and
Community.
Community. So tying that together, looking at episodes of care, including the length of stay, it's what we look at. How do we drive down the length of stay while keeping readmission rates as low as we can? Yeah. So those have to be balanced to their quality.
Yeah, I agree with what you're saying, Kevin. I've been thinking about this from the very first slide, which is all those things, 3 or 4 things on the first slide have not gotten any better. But I think, after COVID, after times we live in now, great resignation, lack of employees has changed the environment that we're in now. And I think it's made trying to tackle these cost questions just that more difficult. Because I think what we're also seeing delivery side is struggle for access, whether it's long-term care, other post-acute care, primary care, specialty care, and we see our EDs, Maine has some of the worst ED utilization in the country. I see it in the MSSP data, and, we've been trying to tackle it for years and we haven't solved that particular problem. But, the lack of employees, the lack of services, I think that's new in the equation here. And that might not be describing it quite right, but we need to think about not just the things that have plagued us for many years, but the new things that are plaguing us now, in sort of the new world we live in after COVID.
But I think you could make the flip side argument that it makes the cost question more compelling, because we clearly need to have different kind of investments. I mean,
I'm not
we
diminishing
need to
it.
make.
Making it harder,
workforce,
making it
not in
harder.
some of the things
Yeah,
that drive
absolutely.
prices today.
Yep.
Workforce, I think, too, and the infrastructure, to the degree we can examine sort of the built infrastructure that we're working with in this state. I mean, I'm sure ED utilization remains stubbornly high, largely because it's the only access point in many rural parts of the state. So, okay, maybe take issue with that, but
No, in rural parts, I agree. What we're seeing, it's high in Portland too.
Right.
Mercy and Maine Med are overflowing. Our EDs are overflowing and there are tons of other access.
yeah,
So there's also a cultural issue.
I know also, and like the data is pretty, probably outdated at this point, so it would be interesting to know, what the experiences have been of hospitals, but in terms of like preventable ED visits, and what's driving those. I know dental used to be one of the larger ones, but,
No, those are both now.
yeah.
But you're right, plenty of preventable.
So, because I feel like there's obviously there's a need for an emergency department that like needed visits versus the preventative ones, and like, how do we tackle those?
I think behavioral health would be the top preventable one today.
Yeah.
Without any question, and those are the ones who get stuck for weeks.
Because they can't transfer out.
Yeah.
There's nowhere to go. Yeah.
and I think you're right that there's lots of choice in Portland, but whether those choices are actually accepting patients in the Portland market, for instance, it's still.
They're accepting commercial. So I think we need,
I don't know.
I hope in these conversations that we can always be talking about the entire population and not just commercial, and really talking about all payers, because they all impact.
And that feels really important to me.
Yeah.
Yeah.
I would say though, I think affordability is an acute issue in the commercial population, whereas Maine Care enrollees don't have quite the cost share or
It's an affordability issue for the individuals. It's also an affordability issue for the providers who are taking Maine Care.
Right.
So I think affordability can be viewed in a number of different ways. And I hope that we can look at it that way. Medicare as well.
It
Yeah, I think
becomes
the
an
statute-
accessibility issues for people because the providers will take the Maine Care.
Yeah, I think the statute, the goal of this commission though is to talk about affordability for individuals and small businesses in the state. Well, I'm correct on that. So, I mean, that's the perspective that I'm just trying to.
Understand, and we need to, and what I'm suggesting is that to do so, you need to look at a bigger picture.
Of course.
Because the bigger picture drives affordability for those specific populations as well, including how the providers get paid.
It's actually a good transition maybe into the next section that I've got where I'm trying to put a framework around the office's work. But I'll just say again too, in putting this presentation together, obviously it's a huge amount of information. And so I really did try to draw that line a little bit under, let's define the problem. I think I agreed thinking about that problem primarily from a consumer perspective. I would expand a little bit to say individuals, small businesses, large employers too, just because of the carry down to individuals. So don't want to make that differentiation, but really from the consumer writ large perspective. And so I did think that trying to go into that next level down of, okay, what are all the driving factors here and what are the most significant was just too much to do in one presentation today, which is why I wanted to start with that. A little bit of laying of groundwork, but I also totally agree. I think that there's a lot of interesting conversations to be had about what we see as the biggest factors and the most significant ones, which again kind of leads right into the vision piece of this and back around to the office's role. Again, acknowledging how big this mandate is, that I thought it was important, even for myself in my early weeks in this role, as I was having conversations with people and doing the thinking myself to try to come up with kind of some guiding principles for the work. I hope you see your thinking reflected here a little bit, Katie, the first being focusing on the big picture, which I kind of define in a couple ways. The first being trying to prioritize opportunities with significant opportunity for impact. And what I mean there is there are so many topics and initiatives and subjects that this office could potentially weigh in on. But in these early days, I'd really like to think about kind of where are the unique opportunities for this office with the breadth of its mandate, and also, well, what are some of the most impactful things that we could do to help consumers? But then also coming back to Katie's point, thinking about the big picture in terms of recognizing the complexity of interdependent systems and actors in healthcare. I agree, especially coming out of legislative session, often like when there's an opportunity to talk about something, it's already framed up and it's focused in one area, and there aren't that many chances to take a step back. So, given my background and work, definitely want to make sure that this office is thinking about all of those, impacts and overlapping interests. So,
And given that you report to a committee that has 2-year terms and a sense of urgency, I wonder if it might be wise to think about defining impact carefully in terms of short-term and long-term, and the note that sometimes a short-term impact has a long-term cost.
yeah.
So that's, I think, a legislative tendency to do something that looks like it solves the problem and in fact has later impact.
Defer.
Flag. This comes to Trevor's point, thinking about this definition of affordability, and that I do feel strongly about the office defining affordability from a consumer perspective. I will say I've used the terminology here, end payers. I think that there are times in terms of thinking about what are impacts on a payer like Maine Care, for example, where there is sort of a consumer impact in the end in terms of those being government sponsored plans, but that really the particular emphasis of the office should be consumer cost burden, and coming back to that delayed and deferred care question that most urgently thinking about what are ways that we can relieve some of that burden that's impacting individuals to the degree that it's impacting their access to care. And I also would like to avoid policies that shift cost, unless the cost shifting is done very intentionally. I think that there are times when a quote unquote cost shift can be to the benefit of consumers in terms of predictability or thinking carefully and strategically about population impacts. But I'd like to avoid, some of the conversation. There's lots that can be done where we're just kind of, squeezing the balloon, as we like to say. And that really, I would like this office to be more focused on what are kind of more sustainable upstream policy initiatives that can be used to actually control spending as opposed to kind of moving it from one type of expense for a consumer to another.
Okay. So the easiest way to address affordability for consumers is to throw more money at it and give them subsidies. And I think that's not the mission of this group. The mission of this group is to look at the underlying costs, and I think we ought to be clear about that.
That's a good point. Yeah, I couldn't add.
It's just like higher education.
Yeah. Well, how handy then, Trish, that you can weigh in on that. Yeah, I guess I would define that under shifting of cost, but I can think about how to maybe tweak this a little bit to be reflective. I agree that theoretically, we could just come in and subsidize, but that I think one of the points that I've been trying to make with the other slides is that the trajectory is so unsustainable that it's not as though, it's just one small population and we can step in and help them and then we're good, that, that's going to outpace the state's budget pretty quickly as well. So. And then my last item here, which is a close one to my heart, is delivering results. I am, really committed to thinking about implementation and making sure that ideas are achievable. I think probably one of the biggest factors here is, recognizing the federal framework in which we are operating, and recognizing what that looks like now and is likely to look like in the immediate future, and trying to think about what are things that are really within our purview as a state to influence, and trying to think through difficult questions early too. Again, I think it's a great forum in this group for us as we're thinking about policy concepts to, raise questions, to work through implementation questions early on. And I will say, I think some in the room could maybe back me up on this. I don't want this to be misinterpreted as me not being ambitious. I'm very ambitious. I believe in pushing hard for change. I think we in Maine can sometimes do things that have not been done before. So this is not to say, that I'm limiting the scope or ambition of the office, but just that it's very important to me to kind of be practical and realistic about policies. And then finally, the last one, which, I hope can be agreed upon in this room, is just recognizing that the status quo is not acceptable. Again, I know as soon as we get into policy, there's always risk and questions about how it will be implemented. But I think trying to start from a place of saying we need to change something, that the direction that we're moving, isn't acceptable for our state, for any payers in our state, for individual residents, and that, we really have a mandate here to try to move something forward to make change is important too. No, this is a big one. Again, welcome thoughts later on, but any other feedback, anything people think is missing here or inconsistent with your expectations? Great, good news. Like I said, this really has been helpful to me in my thinking, and I hope to come back to it from time to time. If there are things that come my way and we maybe have to make a collective decision about prioritization, to kind of use this as a real guide. So then I wanted to move into just a few slides that I put together, coming out of conversations. I chatted with many of the folks in the council individually and had some meetings with others who reached out to me and saw a couple themes. Again, these aren't going to be brand new. It's going to sound a lot like some of the conversation that we've already had, but that I'm seeing as kind of two areas of opportunity that definitely overlap. The first of those being rationalizing pricing, and then also developing an efficient delivery system. And I've got a little slide on each of these to kind of just say what I mean by the terminology. So the first, rationalizing pricing, I will say we saw some of the data. Maine's prices are high relative to national average, despite costs being comparable to national average. So not seeing a clear driver there to explain the higher relative prices. There's significant variation in prices for services across providers in the state, and not much of a discernible pattern about why. Having spent some time with the MHDO data that's available, I've looked at it with a few different lenses, trying to find out, is it the rural hospitals, are they having to charge higher prices because of lower kind of utilization, needing a higher unit price? And I just haven't seen or heard any sort of rational explanation for that. And I think that is a point of, confusion and to some degree frustration among policymakers, others. So worth taking a look at and working to explain or address. And then just flagging, trajectory of premiums and cost sharing in the commercial market being a real risk to access that, calling back to that employer survey that the trajectory that we're on, it probably isn't going to be sustainable for much longer. And so again, really needing to think, given all the work that's been done in commercial markets recently about how are we getting at the underlying drivers that are pushing that. And then the other item or sort of topic area was developing an efficient delivery system. Definitely have heard that very consistently in feedback as I was talking to all of you and other folks as well, that there's a real need for robust, accessible, low barrier preventative primary and behavioral health care that can limit unnecessary progression and sort of generate savings in the longer term, as well as having a positive impact in terms of the consumer experience and health and well-being in the state. So see that as definitely an area of opportunity where I think there's a lot, hopefully, of common ground. There's a need for additional mapping of services and needs across systems and stakeholders. So again, we've touched on some of this: appropriate urgent care emergency services in rural areas and the behavioral health component as well. Definitely have heard about this issue of longer than necessary hospital admissions or folks who are stuck in hospitals who really should be in a different care setting. So see a lot of opportunity there, acknowledge these are big, big challenges, and also want to acknowledge too that I know there's work happening on some of these topics like within DHHS, but I'm hoping that maybe my office can contribute a slightly different lens and a little bit of a broader perspective and a little bit more thinking about the payer component of it, particularly commercial payers' involvement and alignment with some of those efforts. I just jumped to my third point, but I'm excited about the opportunity of thinking about alignment across payers in value-based delivery models that could both generate some savings and improve care. So I would characterize that as a little different from the top two, but related sort of point in terms of thinking about the opportunity that exists to come together around, for example, a primary care delivery model that is strong and effective, and where we could really sort of supercharge the effectiveness of that by thinking about ways to bring payers together. I think the fragmentation between public and commercial payers on some of these issues has been a real challenge in terms of maximizing the effectiveness.
Yes, we were just sort of having a bit of a side conversation, but it would be good to see, we're talking about commercial and public payers, but where, like behavioral health, people that are getting stuck in the emergency departments, but where are private insured individuals getting their mental health care, substance use care? Where are public payer people getting their mental health and substance use care? What types of, private practitioners versus community agencies versus emergency rooms? So seeing a kind of a breakdown of the utilization between those two payer sources for behavioral health care would be really, I think, interesting to see.
The highly two-tiered system that we have in the state.
But I had the same thought on urgent care. We know when we, urgent care and high-tech services, because we know when we take those services out of hospitals, consumers may see a lower cost, but hospitals costs increase. So what do we know about the utilization of urgent care, CT, MRI, all of the kind of high-tech services that may be good for the consumer, but may have one of those unintended consequences of raising the cost of a place-bound hospital that has to have those same services. And if their utilization goes low, their price goes high.
Yeah.
And what does that mean for the system change?
And I would just, an addendum to that would be, what is their payer mix for those?
Yeah, right.
Yeah.
Yeah, because they're probably draining,
They're draining.
are they young and healthy, is it, and what is there anything to do about that? Because on the one hand, it would be a great benefit for consumers, but it then raises consumer prices in another setting. And if we had an effective CON program, these would be not issues, but we don't.
The agenda, so in the future, they have to go there.
Is it still good?
That's a great flag, and my gut instinct is that should be pretty, not, I don't want to say easy, but I would think that we could accomplish that with MHDO data. I think we have everything we need in MHDO to do an analysis like that, so.
Yeah, convenient MD to get sort of the data from those organizations. I think behavioral health is a little bit harder. I'm not sure all those individual psychiatrists are even, that claims are being processed. There's a lot of, I think there's a lot of,
Self-pay.
self-pay.
Yep.
Cash.
Yeah, that's one where, is it Health Info Net, RHIE? We'd have to maybe think about incorporating that to get self-pay and to get all or a higher percentage of providers.
Sure that we're gonna capture them all.
Yeah, again, so I welcome if there's thinking about where to access that recommendations, because I hadn't been thinking of that with the MHDO data, the sort of gap in the providers that would be included. I was thinking, oh, that's pretty granular. We could probably pull it, but you're right, it would only reflect some of the bigger players. Yeah. Great, I will add that to the list though. Any other thoughts on this slide? I will just say, I think I've had a few conversations already and continue to want to dig in. I think a topic that would be especially great to discuss in this group is some of that thinking about multi-payer alignment, you know, what that could look like and what would be needed. Because again, it does feel like there's a lot of mutual interest and kind of aligned interest in that area. So just kind of flag that as an item for follow-up. Yep.
I'm not sure it really belongs under efficient delivery system, but it maybe does. One of the data points that I don't see that would be interesting is what percentage of premiums are spent on patients in that state or something. We don't have much at all here on the insurers and their efficiency.
Yep.
And that would seem like important set of data to include as well as the provider data.
Yeah, I think we could pull that. I mean, with medical loss ratio, there's definitely access to that. And we sort of know there's a little bit of a ceiling or floor, I guess I would say, in terms of percent of premium collected spent on healthcare as opposed to other administrative costs. But I think that some of that data is public already.
Yeah, it's also challenging because speaking as a very small carrier, we don't have millions of subscribers to spread our costs across. So it's
Just saying,
I'll just put it out there.
I understand and actually,
We're the most transparent
I know
of any
I'm not.
carrier because, it's all Maine, it's all individual, small group, large group, all commercial. So happy to get into it, and talk about what the data shows and also limitations.
I think for the purposes of MLR, that like you said, and Kevin, you would know better than me, but it would be for that market, whatever you're reporting on. So it would be like Maine's, merged market or Maine, you know what I mean? So I think it would be Maine based, even for other carriers.
Oh, yes, and
Right,
there's a lot of
yeah,
maneuvering
right.
of data points.
And it seems like that might be important for us, like the hospital data.
Nope, fair, can definitely pull it. I do agree that I think there is a lot of flexibility in definitions and things like that, but we could kind of go a level deeper on that and take a look at what's available. That was all I was thinking was there's a framework there, imperfect though it may be, that's sort of existing in terms of that concept of trying to ensure that if premiums are outpacing spending, that there's a return to consumers on that.
Do you see this office having any role in the rate review process at the Bureau of Insurance?
Yeah, it's an interesting question. I don't know about formally, it's not sort of written in. That being said, I definitely think, given the purview of the office, that yeah, it's an area of interest of mine, definitely to dig in a little bit more and be part of those hearings. I think similarly, Clear Choice Design Committee, sort of some of those areas where the Bureau is thinking about and setting policy in terms of consumer affordability, that I definitely like to at least have a seat at the table for those. We have on time still. It's great. We might even be, I think maybe we're right on time. but I think we've been generous here, but plenty of time for discussion at the end. Just a few slides here in terms of next steps to kind of set an agenda for out of this meeting. So wanted to re-review just the big milestones that I see ahead. Again, first public meeting in September. I'll probably be trying to set a date for that, honestly, in the next few weeks, just to get it on calendars, because again, it's going to be here before I know it. The framework for that is pretty high level in the bill. So I'm directed to review cost trends and barriers to healthcare affordability and then provide an opportunity for public input on that. So again, see this presentation as a foundation for that, but we'll be building out based on all of this input and welcome other thoughts from this group about how to make that a useful forum for people and how maybe to create some kind of framework for the input from the public too, whether that's like phrasing a set of questions that can be handed out just so that there's something where, yeah, it's not a wide open kind of opportunity or where I can give people an idea of kind of what's helpful from them. In October or November, I would love to do what I'm calling a retreat. Maybe it's a forum, haven't landed on the exact language yet, but I thought it would be great if this group is willing and open to it to maybe bring people together for kind of a full day of talking more in depth about the underlying drivers here, policy options, bringing in folks from other states and maybe some national organizations, kind of modeling this on something we did about 4 years ago, where there was a forum that DHHS hosted that was really focused on coverage expansion and affordability, but can structure it a little differently. But I just found it really nice to kind of have some set aside time, and hoping that that timeline is helpful kind of before things pick up with the legislature and everyone is really busy again. So also wanted to propose inviting members of the HCIFS and HHS committees to potentially join that group. I think they'd really benefit from the time spent on this and would welcome that opportunity. So
Might be 3 days.
yeah, I did wonder, should we do a real retreat, get a camp somewhere and we can all hunker down? So we'll see. It's a lot, I know, to squeeze in, but
$40,000.
yeah. I was actually just thinking yesterday about like the invite list needs to be all folks who have their own budget for travel, because I don't have a whole lot to share with them. But from past experience, I often find there's a lot of folks who are really excited to come and share their experience and thoughts. So it looks like I'm seeing nodding heads, so I'll take that as a sense that that sounds like a good idea.
I'm fairly certain that that group of us could probably, arm twist a little bit and get some people here.
Sounds good. Call
I
in that.
love adding HHS.
Yep.
One of the biggest challenges we have is the split in the committees,
Yeah.
and
Mhm.
it's just doesn't make any sense.
Yeah, it's interesting. When I first wrote this, I said HCIFS, and then I gave it a little more thought and thought, I know there's members of the HHS committee who are really interested as well in these issues. So I
Plus
think
it's
that
the
would be great.
commercial and
Yeah.
public.
Yes.
Yeah, split, yeah.
Great. That'll be fun. Looking forward to it. I'll jump. I've got a slide next about kind of next steps on planning some of this, but can follow up about some of the logistics of that, but glad to hear others think that that would be a worthy use of time. The last item that I had is just January of 2024 being the requirement to deliver my first report. So the general report on the office's activities that's required, and then also a report that's responsive either to that initial unallocated language or to the amended version coming out. I will say, in a prior role, I spent a lot of time on public options and Medicaid buy-in type proposals. So I know that world pretty well. If I didn't, I'd be more anxious about that timeline, but I think we can pull together. What I'm really thinking of is more a design paper. I don't think anyone on that committee has dug in really deep and has a model that they are committed to. So I think giving a sense of here are what models can look like, here are all the decisions that you have to make in a public option model and what some of the trade-offs of them are is probably the most helpful thing. So that's what that report is going to look like. It is not going to be a policy design with an actuarial analysis of premiums and sort of that level of depth by any means. I think we're several steps away from that. I've got my agenda for the next meeting, but the first couple items of kind of council business. I was thinking we can do this informally, but we can see if we need a vote or a poll or something afterwards. But I would really like to just set a regular cadence for meetings so everyone can get them on calendars and kind of hold the time and stick to it. Wanted to propose second or third Tuesday of each month in the early afternoon, essentially just sticking with this timeline. Maybe I'll pause there and just try and get a sense from the room. Do folks want to just land time and go with it, or would you like to kind of try and do a survey process? I did find that a little hard last time. I had hoped I could land a time that worked for everybody and it just didn't work. So are there strong feelings, or should we just kind of lock in a time and send it?
I would lock it. It'd be better for me because I have a national meeting on the third day.
Okay,
You know, I prefer mornings. Afternoon, but that's just because of me, but I can accommodate.
why don't I won't do a date specific, but maybe I'll do kind of like 3 options for time and cadence and send it out. And I'll just say whichever one wins on the numbers I'm gonna go with, if that works for everybody.
And if we have it as a hybrid, it makes it so much easier for those of us who travel. So
That's what I was just gonna check. I assume that the group would like to do hybrid moving forward. That works for me.
saves.
Perfect. Yeah, and I'm much more comfortable with that now that I know how to run everything. And here, yeah, I was a little, you never know, even after all these years of it, there's always still seems to be a glitch, but this was pretty smooth. So that should be fine. I welcome that. I actually was, I mean, if folks really want to do all virtual, we could go to all virtual, but I think it's preferred to be hybrid, right? So there's in person for public.
Yeah, the statute that was passed, I think, requires at least hybrid unless there's an emergency consideration.
Okay.
I would have to revisit the specific bill language. Yeah, there was something passed in the last session.
Well, I will be somewhere here in Augusta then, and hopefully from time to time, others will join me. Okay, great. That's good. That answers the question then. We'll stick with a hybrid schedule, and I'll see if we can have a consistent space here or maybe move around a little bit, but I think probably it will be here in Augusta most of the time if that works for others, since it's a haul to Portland for me. So then the other kind of item of business is electing a chair and a vice chair. Didn't want to spring that on the group during this first meeting, so wanted to propose that we could have a vote on that in the next meeting. Just briefly, kind of my thinking about these roles, you know, envision the folks in the roles helping me to set agendas for meetings, and in particular, you know, advancing if there's topics that you feel like the council wants to talk about that might not be on my radar, sharing that. Definitely taking more of a role in facilitating these meetings. I can kind of split those duties, and there may be sections that I facilitate, but would kind of formally be the lead for these meetings, and then providing leadership in terms of the council's role. Again, it's a little open-ended, so helping to determine when are times to formally weigh in and what should be the format of that. I wanted to propose self-nominations or other members nominating someone from the group, and thinking folks could send around a quick email sharing nominations to the group before the next meeting. And then figured we could kind of do a chair vote, and then from remaining candidates vote on vice chair. This is my first time facilitating something like that, though, so wanted to get some thoughts on both that process, and then, you know, certainly if there's thoughts on kind of qualifications or the role that the chairs and vice chair should play in kind of facilitating the group, since this is really a discussion and decision for all of you.
It seems to me that we need some level of sort of rules to govern us and what the guardrails are. We are advisory. That that individuals can't speak for the group speaks as a group through its chair or through you. I think some of those things we probably should get in writing. Very simple. I mean, don't make it a big bureaucracy, but I think that would be helpful. Because especially as we get into some of the thornier issues. And my sense of chair, I mean, it sends a message about how you define, you've limited and focused this, and it seems to me it should be one of the end payers.
That makes sense to me. And I will say on the question about kind of rules and structure, it is a good flag. I had checked in with Heather. It was a little last minute for me again, first time facilitating this, but had recently been looking back at some other agendas for first convenings. And even though it's not formally required, we did chat about a set of bylaws and thought we could draft something up for the next meeting. So maybe that, I don't know if that's too formal for what you're talking about, but sort of setting a little
Do
bit
we
of a
vote?
parameter.
Do we vote? Is it consensus? If
Yeah.
we vote, what's, just,
What is
you don't
that?
want to get into a hoorah and then have to
Yeah.
figure out what the rules are.
Yeah.
Yeah. Simple charter.
Yep, charter.
Is that something we can do by email, in the interim?
I think so.
And then vote in, not.
Yeah, if it works, I can work on drafting something. Oh, sorry, not to cut you off, but I would think that there may be examples that I can take a look at and I could provide something and the group can edit, so it matches, but I can at least take a first cut at what that could look like.
Audit form, if you had something in place for them.
Probably.
Yeah, and the rural, the office, the rural, group that Lisa Letourneau has been chairing also, I think, has a charter.
Okay,
Yeah.
check with her when she gets back from riding across the country on it.
Yeah, I think so.
You are at the planning board, might you know that.
State so,
Yeah.
I was gonna look at theirs for bylaws, so I don't know if they have, PDAB.
Yes, we do.
90% sure they do.
They might be a good example too, because I know they've also been navigating sort of their statutory authority and also their collective voice, if that makes sense, and how they implement that.
And we're advisory, so it may well be you do something that we didn't advise.
Mhm.
That's fine. That's the nature of an advisory. And then what are the rules for the advisory group?
Some of it is defined in the statute, but can certainly be summarized in a sort of charter document.
Yeah, I agree. I think the line between the forum for informal feedback that this sort of convening creates versus if there are times when the group sort of wants to collectively take a vote and weigh in a more formal way is worth considering. Carl, saw that you had your hand raised.
Yes, thanks, Meg. I was just wondering, for the purpose of the elections, can you send out a updated list of the council members and organizations so that we know really who's on the council for nomination purposes?
Yep, absolutely. I think I sent just before sort of around 12:30, just before this meeting, some documents out to those of you who are joining virtually because I printed them off for the folks in the room with the list of advisory council. So I think that you should have that, but I'll also, after this meeting, I can follow up and send it to everybody just so everyone has a digital copy. Thank you. Sounds like a plan then. Brings us to kind of my last slide, just reviewing what I've mentioned in terms of meeting agenda items for the next meeting, which I presume will be in August. I just realized I didn't formally ask, but we're required to come together every 2 months. That felt like a good cadence to me. It feels like it gives some time to really have a fully built out agenda. But I also welcome if the group wants to meet more frequently, we can certainly do that too. So I don't mean to dictate that with my August, but I figured especially maybe in July, people might be hard to land a time when everyone can get together. So again, plan to review the plan for the public meeting and a more built out agenda for that and maybe have some feedback and discussion about the format for that. Would love input, as you mentioned, get more in depth in the planning for that fall retreat. I'd really love to lock in a bit of a framework for an agenda. So hopefully we can get invites out, no later than that time and make sure that it's meeting, needs and expectations of this group. And you can help me if I've missed any thinking about what we should cover, what would be of most interest. We'll cover all those administrative sort of business items and start off probably with some of the formal votes just to get ourselves formally established. And then I just wanted to check if there's anything immediately beyond some of the data questions here. I will say, if I'm able to, I'd love to come back with some more analysis for this group, maybe building off of what's been raised here and some of the flags. So would, be happy to see how much we can accomplish between now and then. And at least on some of them, I'm pretty confident we'll be able to flesh out some slides. But anything else that, I didn't cover today or that you'd all like to make sure is on the agenda for the next meeting? This is another where welcome emails later when everyone's had a chance to think through. Okay. So that was the end of my formal slides. I had one quick appendix just for all of your information because it's another question that I've had about similar entities in other states. It's a little small here. There's a lot of them. There's 2 pages of it. Where I just ran through, and some of this is based on conversations, others on publicly available information about my counterparts. I will say there is a lot of coalescing around this concept of cost growth benchmarks. So that's what the majority of the other states with similar offices are looking at. Some of them are just starting that process. Others have implemented them and are thinking about performance improvement plans or whether they want to create sort of more incentives or consequences for folks not meeting them. But that really is kind of like the area that most other states are looking at. There's a few others, Colorado, I would kind of call out in particular. They've been very active in using their health insurance review process to think about cost control. So they've got what they're calling a public option, although it's a commercial plan, but with extra requirements. I kind of have been thinking about it as like a standardized plan supercharge, where the plans are tasked with meeting benchmarks for premium reductions over time. And if they fail to meet those, their Department of Insurance can step in and regulate prices. I think they're kind of working through, they've sort of gotten through 1 year of that program and are just starting the conversation about what that looks like. But they're kind of probably the most hands-on and active, so thought I'd mention them. But again, otherwise, just a lot of talk about these cost growth benchmarks. And from what I understand, may have been the initial iteration of sort of the legislation creating this office, which changed slightly, but just in case it's helpful. And I have collectively connected with pretty much all these folks, and some of them have spent more time with than others, kind of chatting with them and learning from them, and plan to continue that. I always like to, especially since I'm an office of one right now, kind of connect with others in other states so I can avoid, making mistakes that they haven't kind of learned from their work. So just thought I'd call that out. Not going to step through all of them, but something if you all want to look through just to familiarize yourself.
Has any state defined affordability?
I think the state that has come closest is Connecticut. They have done a health affordability index, I think is what they call it, that I think was regional, and they were trying to think about cost of living in different parts of the state and then define kind of what is a percentage of income that's reasonable to spend. So they're the only state I know of that has done that work, and I'm not sure how much they've really utilized it. But they're the only ones I think that I'm aware of who have kind of dipped their toe in the work of trying to figure out what a line is.
Yeah, it would be really great if we could get some sort of consensus around what affordable means, right? Yeah. I think we all probably recognize it's not, whatever affordability is, it's not there now, but.
I think I would agree. Yeah. And yes, how do we even know?
Yeah, how do you measure success, right? If you don't even know what affordable means, yeah. Really, agenda items for the group.
Yeah. It's
That'll be easy.
It can, it's a bit of a quagmire. One of the last papers that I contributed to before I came to Maine was talking about exactly that problem. And there's just so much differentiation, I think, between income levels, even if you're trying to think about a percent of income, 5% at one income level, it feels very different than 5% at another, for example, and then also kind of the utilization question of, is it a one quote unquote bad year in a family versus folks who kind of have those ongoing costs. So I think it's really interesting, but I also think there's a reason why others have struggled to define it. It's not for lack of trying, I guess is what I'd say. I'm happy to pull that Connecticut information a little bit more though and bring that to the next meeting if that's of interest.
I think it might be a good idea to be aware of the work that the Prescription Drug Affordability Board has been doing. Since there's going to be some intersection.
That report with the group.
The PDAB report, not with this group, no. Yeah, can definitely do that. I will say, I think trying to think through whether to share the work. I mean, we can certainly share the work to date, but I also think that digging into that question of the setting of the targets, that's kind of the statutory duty, is a little bit like we're in the midst of it now. So, but yes, it is a good flag. I don't know if there's any more you'd say about them, Heather, that's helpful to know. Again, like I said, there's this very specific statutory duty, but then also definitely some involvement in some weighing
There's
in on
a very
others.
specific statutory duty that they really haven't been able to address. They don't have any staff support, but health industry analysis. They have been looking at a very broad policy level. And that's mostly what they've been providing back to them.
This is kind of an auspicious day for this first meeting, because it's also the day when, all our rates for individual and small group market for 2024 are being posted. They were filed on Friday, but I think everything is being published today. And Magera is, we'll be talking a lot about Magera, I'm sure, and the changes due to the merge market result in anywhere from a third to a half of the rate increases are attributed to Magera's changes. So it's, I fully expect September will be lively in terms of public comment. But it's going to be hard, I think, to translate that to anybody who really is not going to care when it comes to affordability. You know, Magera's changes, you know, why should that influence me? But we're heading into some stiff resistance even as we start to try and make positive change.
Here, well, I can wait and look at the numbers. I was going to ask about trend in small group and how the program was looking there, but I won't put you on the spot. I'll anxiously be awaiting. I didn't actually realize that those were going to flip today.
And the other big factor, of course, is 2022 experience, because 24 rates are based on 22 experience trended forward, and 22 experience was for us pretty heavy. As one would expect after the dearth of utilization in 2020, 21 and 22 came roaring back, and it's not unexpected, but it is what it is.
Yeah. Very interesting. Takes me right back to the question about Medicaid unwinding too, and population factors.
Well,
It'll be interesting
I'm
to see.
hoping that we get as many people in from the unwinding as we can into the marketplace.
So are we.
So are we, yeah.
Signing them up as fast as we can.
And not just those who need some elective procedures.
No, we have a whole team, I think, like this too, that does nothing but enroll people and patients
Yep.
through primary care.
But Carol's recommendation
Exactly.
is just
Yeah.
wonderful.
She's still there, yes.
It's a tricky one. Looking forward to seeing the data on that as it comes out, but it's a hard population to find and to work with. But I know the teams that do
If
change
it's blue, it's time to renew.
Yep.
If you signed up for mail.
I was gonna say, unless you get an email, it's
I know.
I do
I
think
thought it
that
was good though.
some comparative data related to insurance in Maine versus other states would be really interesting to look at, because we don't see that very often. I mean, we have some on premiums, but maybe on administrative costs, those kinds of things that, Kevin, this is actually not at all aimed at you, but we have consolidation of insurers, and that basically I think 3 in the state
Right.
plus Joe, so the nonprofit insurer. So I think it would be helpful.
Yeah, absolutely. I will
Right.
say a factor in that for me in this presentation was just the challenge of finding like a good data source. It's so much more segmented, and there's some better kind of analytics work, I think, on the spending side. But it's a very fair point and one I would like to dig into too.
Yeah, we could, actually, that's something we could tackle, the fact that we
Yeah.
don't have good source.
In thinking about data, again, not necessarily applicable to all insurers, but, some of the like vertical integration that's happened and, owning your own specialty pharmacy or, it'd be interesting to know how that
I was
changes
just
things.
thinking the drug space is probably particularly relevant here.
Well, primary care. Optum is the largest provider of primary care in the country.
There's a lot of data about the consolidation of hospitals and the impact on prices. Is there any on this?
Right, that's what I'm trying to.
Yeah.
I think that there must be, yeah. I'm trying to think
I
about
haven't found
others.
much that's state specific.
Yeah, I was thinking more national. I don't know that I
Yeah.
could find state
And I
specific.
feel like when I've tried to look at like the state level, it's really difficult to find data around that. That's public at least.
Isn't that interesting? Since all of ours is out for the world to see.
They're not nonprofits.
No, that's right.
Yeah, one. But they're owned by profits or, yeah.
Yeah. Another report that might be good for folks to see is that first report that came in on the behavioral health spending in Maine, the MHDO, Maine Quality. This got reported, I think, this spring to the legislature.
I'd heard about that,
Yeah.
that charge that they had, but I think when I was reading about it, they hadn't maybe released the report yet, so I'll go back and find that too.
It's their first time starting to do that. Now they'll be doing it on a regular basis, but.
And I've, it was hard again coming in right in the thick of legislative session, but Karen Lee and I have got a ongoing meeting series set up now. I know that was another question, was this office's interaction, but we've got some good history working together. So definitely plan to kind of be able to collaborate with her, hopefully, and make sure that we're not reinventing things or, making sure we're accessing and utilizing as much of the work that they've already done in MHDO as possible. Great, we're right at 3. Setting a good bar for timeliness. Any other items?
Mostly done.
Yeah, it's very nice.
And
The amount of work that went into pulling this all together. So like, I know like there was a lot of questions about like, oh, what does this mean? Or does this consider this? And just like, really, like this is an incredible amount of information that had been compiled. So thank you so much.
Thanks.
Seriously.
It's been really fun having a little thinking and reading instead of just being in meetings all day, every day. I really welcome it. So glad it's helpful.
It's an ambitious agenda.
It is. I'm an ambitious woman, Trish. Great. All right. Well, thank you on those of you joining virtually. I think we can let you go while we wrap up in the room. Good to virtually have you joining us, but hope to meet some of you in person soon. Bye-bye.